Okay, welcome everyone. Hi, my name's Alison Mundell. I'm one of the principal pharmacists in the MedSop team at the CCG. And I'm very excited to welcome Chloe, Stewart and Helen Patten today to talk about how to facilitate behaviour change, which is one of a part of a series of our MedSop training. We will be recording the session, so if you could keep your cameras on mute, that'd be great. And if you do have questions, please could you type them in the chat box and we can look at facilitating those later. And also, Chloe and Helen have asked if you could introduce yourselves in the chat so they can see who's here today. So without further ado, I'll pass you over to Helen and Chloe. Thank you.
Thank you so much, Ali. Zach, could you put up our first slide, please? Thank you. So today we're going to spend the next hour and a half thinking about behaviour change. And as I'm sure many of you will know, that behaviour change is a very complex subject, and I'm sure you'll have done trainings in the past. So normally when we do this type of training, it can take anything between 1.5 to 2 days with ongoing reflective practice. So this is certainly just a toe in the water, and we're really pleased to be here with you today. Next, please, Zach. So my name is Chloe Stewart. I'm a health psychologist with a specialist interest in behavioural science. I've worked within the NHS for over 15 years now, and I'm also a member of the Motivational Interviewing Training Network. And I'm really pleased to be here today with my colleague Helen, who I'll get to introduce herself as well.
Thank you, Chloe, and hello everyone. So I'm Helen Patten. I'm a physiotherapist by background. I work as an advanced practitioner in a musculoskeletal service in Sussex. I'm also a certified coach, and behaviour change is definitely something that most people come to talk to me about when I see people for one-to-one coaching programs. So it's a very common topic. I've also got a real interest in person-centred care and have worked with in a personalised care lead role, so supporting my colleagues to implement personalised care. Next slide, please, Zach. So just to run through the session today, as Chloe said, it's a really big topic, behaviour change and motivational interviewing, but we really hope to give you an overview and provide you with some core skills and practical tips that you can use in your day-to-day practice. So Chloe will start by taking you through the complexities of behaviour change. We'll move on to how to engage somebody, how to start having a conversation. And then we'll hopefully give you a really clear 4-step process that you can use in your conversations with people. And finally, how behaviour change fits within the personalised care model. Next slide, please, Zach. So first of all, we'd really like to wake you up and just to ask you what your thoughts are and get your feelings about behaviour change and what you think helps people. So we're going to start with a Menti poll, which you may have used before. So Zach's kindly put up the link, actually Ruth's kindly put up the link in the chat box. If you go to either your web browser or your phone, type in menti.com and then the code you can see on the screen. The question we'd like to hear from you is what helps people change behaviour? So we'd just like 1 or 2 word answers. They will appear on the screen, and just as many answers as you like to that question. So I'll give you a moment to locate menti.com. Brilliant, thank you, Zach. So motivation, yes, definitely. A reward for change, their own desires, picturing success, actual harm, yes, so almost the fear that gets involved with needing to make a change, life experiences, knowledge, definitely. I'll give it a sec. And reward for change. Yes, needing to want to make a change. Pain, yes, a good point. So again, the difficulties that go with needing to make a change, and absolutely support from family and friends. So we'll keep hold of these and send them out to you with the slide pack. But I think it really summarises that behaviour change is quite complex, but also it comes down to an individual's motivation and what they really see as the end result and what they can picture as a positive change. Thanks very much. Let's move on. So I'm going to hand you over to Chloe with our next slide. She's going to talk you through some more of the complexities of behaviour change. Thanks, Chloe.
Thanks, Helen. Thanks, Zach. Okay, so I'm sure many of you will have seen this model before, the wider determinants of health model. I think it's really helpful when we start thinking about behaviour change to really start with this model, because we know that health behaviours are impacted by wider determinants of health. And this model really highlights that our individual health behaviours are broadly shaped by our social and our community networks, our general socio-economic, cultural and environmental conditions, including things such as living and working environments, access to employment and education. And all of these are important determinants of our behaviour and health outcomes, and they really must be taken into consideration when we're thinking with someone and supporting them to change a health behaviour. Next slide, Zach. So wouldn't it be absolutely fabulous if the provision of new information reliably led to behaviour change? Next slide. But unfortunately, the relationship between being given new information and enacting behaviour change is tenuous and actually influenced by many competing factors. And you can probably relate to this when you think about your own behaviour change. Next slide, Peter. So people and change, what do we know? Well, we know that people change when they are ready, willing and able to do so. All of those three ingredients need to be in place. And what's important is that we can influence whether or not someone goes on to change by the way that we communicate and interact with them. And we also know that what people say and what they believe about their own change is important in facilitating the change process. Next slide, please. We do hold some common beliefs about why people don't change, and you can see some of these beliefs on this slide, that people don't change perhaps because they don't see the problem. They're in denial, they lack insight, perhaps they don't understand the problem, perhaps they don't know how to change, perhaps they don't care, or perhaps they're just difficult. And this is really seeing behaviour change within what we would call a deficit model. Next slide, please, Zach. And if we hold these beliefs about behaviour change, then a common sense solution would be to try and fix it. Next slide. And so how will we fix it? Well, if people don't see the problem, we would give them insight. If they didn't understand the problem, we will give them knowledge, tell them everything that we know. If they don't know how to change, we can teach them step by step. Or if they don't care, then we can just make them feel afraid, make them feel really bad, and then they will magically go off and change. Next slide, please. And actually, what we know is that behaviour change and is not about seeing people through that deficit lens. And actually, a core part of behaviour change has a lot to do with ambivalence. So I'd ask you just to take a moment or two to think about what ambivalence might mean. And then we're going to go on to the next slide, please, Zach. So ambivalence is when we simultaneously want and not want something. It's arguments for and against change that reside within us. So, for example, I really want to stop smoking, but actually it really helps me to relax, or I really want to be physically active, but going out in the dark is something in the evening that I just don't really want to do. And we know that being ambivalent about behaviour change is normal and common and part of the change process. And we also know that unresolved ambivalence is often the reason why we get stuck. And so our roles as practitioner is to support people to resolve that ambivalence. Next slide, please, Zach. Because we've come into these helping professions, often we come in with a powerful desire to prevent harm and to make things better. We want to support people. And sometimes we see people going off in a certain direction and something triggers within us and we want to pull them back and set them on what we consider them to be a better path. If they just took this medication, or if they just stopped taking this medication, we could see that life would be completely, their health outcomes would be better. And this is known as the righting reflex, and it comes from a really nice place, but it can often get in the way. Because what happens is when somebody holds arguments for and against a behaviour, so that ambivalence, if as a practitioner we take on all of the reasons why people should change, what will happen is they will tell us all the reasons why they should stay the same. And they are more likely to dig their heels in and fight for their right to remain autonomous, so fight for their right to stay in control. So what we want to do is use techniques which allow that person to elicit their own reasons for change. And we want people to verbalise these, because if they verbalise the reasons for change, they're much more likely to enact them. There's a saying in motivational interviewing: we know what we believe when we hear what we say. So what we need to do as practitioners is to become really good at active listening, so that we can start to elicit from that person their desires and their motivations, as you've already articulated, for change. Next slide, Zach. So we need to make a shift in our own behaviour as clinicians. I'm sure many of you are already doing this and perhaps are very skilled at it, but we need to try to move away from that desire to be a teller and fixer, which comes from such a good place, to being an asker and a partner. And that's where we're going to move to today, to think about what skills can be put in place to allow us to be more of a partner in the conversation. And I'm going to hand over now to Helen, who will take us on to the next step.
Thanks, Chloe. Next slide, please, Zach. And the next one, thank you. So just thinking about the ingredients or the components that we need in order to make a change to our behaviour. And if you think about your own behaviour, some of these will definitely ring a bell. So the COM-B model talks about the 3 components necessary to make a change. So understanding what drives behind this behaviour change helps us to facilitate it. So first of all, capability. So that's both the psychological and the physical ability. So it's having the knowledge and the skills and the abilities to make a change. So then the O, we have opportunity. So this means having the social opportunity. So that might be social cues or cultural norms, as well as the physical opportunity. So having the time, the location that you're in and the resources to make a change. And then finally, motivation. So this refers to our internal processes which influence our decision making and our behaviour. And we can broadly divide these into our reflective motivation, which is our ability to make plans and to evaluate, as well as our automatic motivation, which is our impulses and desires, as well as our inhibitions. So these 3 components act together, and we need at least one of them to be really strong to enable to influence the other 2. So it may be within your conversations that you notice what particularly somebody might need in order to drive their change. Next slide, please, Zach. So now we're going to move on to this 4-step process, which we hope will be really clear and quite simple as a a way to frame your behaviour change conversations. So this process is taken from motivational interviewing, and it starts with your engaging, so connecting with your patient, with the person you're talking to, moving on to focusing, so really finding out someone's specific agenda, then moving on to evoking, eliciting your patient's own motivations for change, and finally planning, so how to take the next step. And through the next slides, we'll hopefully break this down into quite simple steps. So the first step, next slide please, Zach. So engagement really is the foundation for making it a change or supporting someone with behaviour change. And in motivational interviewing, it's quite often called the spirit of MI. And motivational interviewing is really grounded in building rapport and in building connection. And we know that engaging and establishing good working relationships is a prerequisite to everything else that follows. We know from research that the quality of clinical engagement and the formation of a good working relationship really predicts retention and outcome. And interestingly, we also know that if the consultation starts with an assessment or a very biomedical type approach, it can place the patient in a passive role right from the start, which really compromises their engagement. Next slide, please, Zach. So again, from MI, this idea of the spirit of MI really works around these 4 points. And it's about having the heart set and mindset going into a conversation. I think sometimes we think, or we sometimes think about people as being difficult or having difficult conversations. And that comes back to the writing reflex that Chloe talked about. But really entering into your conversation with collaboration, so the idea of a partnership approach, rather than done for somebody, it's with somebody, really honouring someone's autonomy, so that's acceptance, having absolute worth for somebody, and that knowing it's the client who decides or the patient who decides what they want to do. Evocation, which we will expand on a bit more, but that's really eliciting someone's own motivation for change and their own preferences, which we know has much more likely to make a difference long term. And then finally, compassion. So it's that honouring the best interest of that individual. Next slide, please, Zach. So OARS is a really useful framework, again, that comes from MI, and this is a way to underpin your communication or to give you a framework for your conversations. So open-ended questions are a really useful way to get somebody to tell their story. And whilst you might not use them exclusively, they can really encourage you to get a greater understanding from an individual. Affirmations. So these are statements or gestures that recognise somebody's strength and acknowledges their experience. There might be some examples of questions such as, I appreciate you're willing to talk to me today, or you're clearly a resourceful person, it seems like you're good at something. These questions really help to build confidence. Reflective listening, so that sounds quite easy, but actually it's more difficult than you think. I think it's very easy to misinterpret what somebody's saying. So by using their own language, so reflecting back what you've heard in somebody's language can be very powerful, or rephrasing, so using language that's very close to what you've heard someone say. Sometimes emphasising the emotional aspects of communication through feeling statements, such as, I understand that could be difficult for you, or I can see that you feel frustrated about that. So that really makes someone feel as though they're heard. And then finally, summarising. So summarising can help somebody to take the next steps towards change. It can be summarising at the end of the consultation. So, for example, let me see if I've understood so far what you've said, or it can be a linking summary. So I mentioned that you wanted to explore a different type of exercise. Do you want to talk about that more? And it's always useful to end your conversation with an open question. So would you like to add anything else? Next slide, please, Zach. So our next step in the 4-step process is focusing. So this is really about getting to the real nub of what the conversation is. So Miller and Rolnick describe this as the process by which you develop and maintain direction in the conversation. Next slide, please, Zach. So one way that we can really focus our conversation is with agenda setting. This is also sometimes called contracting. You might have heard this if you've done any coaching courses. Contracting or agenda setting is a way to hold the conversation. So strategic focus within that. I sometimes describe this as you as the clinician holding the process or holding the framework of the conversation, and your patient holds the content to feed into that conversation. It can be really useful to establish boundaries. So that could be talking about your role and the time that you have together. It may also be being really clear with someone about what makes them feel comfortable to talk about, or when they want to take time out from the conversation. And then finally, establishing the purpose, and that can be as simple as asking what's important to you today, or what matters to you, or what do you want to get from this conversation. On to the next slide, please, Zach. And I'll hand over to Chloe to take you through the next step.
Thank you, Helen. I wonder if we might just take the slides down for a couple of moments and just to hear from people in the room before we move on to evoking about the things that you've heard, what that has triggered within you, any thoughts, reflections or questions that you might have. Is there anybody who want to come in? It might be just thinking about things perhaps that you already do that perhaps you hadn't labelled. So perhaps it might have been how you engage with somebody, or do you already do that kind of focusing, that joint agenda setting?
I think I agree with the is it Nikki Wade? Sorry, I'm a sister in the pain clinic. I very much agree with finding out the patient's own reasons for change, and that is so powerful. Once you've addressed and found that out, then it's so much easier, I think, for you and the patient, because you know what their motivation is. I've definitely found that is very strong.
Thanks, Nikki. Yeah, absolutely. So really spending that time eliciting from that person what matters to them is really important, and something that sometimes we don't always do early enough in the conversation, but it can have such an important impact on engagement as well, and that person feeling heard. So thank you. Are there any other thoughts or reflections before we move on? It's absolutely fine if there's not. Please do use the chat function if you would like to add a comment, a reflection, or if you've got a question. We really do want to hear from you. We're moving on now to the next section, which is about evoking. So really, how do we elicit from the person their motivations, their desires, their wants? So we're moving on to the evoking section, and there's going to be an opportunity in this section for you to go into breakout rooms in pairs and to try some things out. So we hope that you're willing to do that today. Zach, if you could just pop the slides back on again. Okay, so as I said, so eliciting people's motivations for change is absolutely key. And I'm sure this is something that many of you will already be really skilled at. So hopefully this will very much just be a refresher for you. But what we will do is, well, Zach is doing now, is popping you all into pairs. So you will all have the opportunity to go into a breakout room. And what we want you to do, once you've introduced yourselves, if you don't know your partner, is to put yourself into either the role of speaker or listener. And it really doesn't matter what you, which role you are. And if you are in the role of the speaker, we would like you to share with the listener something that you would like to change or you've been thinking about changing. And my offer to you is to think of something that's real. And we call this real play rather than role play, because actually feeling what it's like to have this type of conversation can be really powerful. So of course you have to feel comfortable about sharing something that's real. So if you don't feel comfortable sharing something that's real, then absolutely just make it up. That's fine. And what we would like the listener to do, if we go on to the next slide, please, Zach. The listener, we would like you to just ask these questions in this order. Please don't deviate from the questions, but just ask each of the questions in turn, and then end with the statement, so what do you think you'll do? So we want you to start by saying, the speaker will share with you what the thing is that they're thinking about changing, and then we want you to ask, why might you want to make this change? And just listen to what the person says, and then ask them, what are the 3 best reasons to do it? And then we would like you to ask them, on a scale of 1 to 10, how important would you say it was for you to make that change right now? And then depending on what they say, we want you to ask the following follow-up questions. So, for example, if the person has said it's about a 6 out of 10, we want you to say, why did you rate yourself a 6 and not say a 3 or a 4? And then we would like you just to listen to their response and then ask, if you did decide to change, how might you go about changing? And you will have to have listened really well, because we would like you to provide a summary of what the person has said, including any expressions of their motivation for change. Please don't regurgitate the whole conversation. So just those key summaries, and then ask them, so what do you think you'll do next? So that's the activity. And I think Zach is going to try to feed these questions into the chat. But if you do have a phone and you can take a picture of this slide, I think that would be really useful so that you've got the questions to hand. Now, before we put you into breakout rooms, are there any questions, queries about this exercise? Wow, thank you for that. So apologies to those people who had a really abrupt end to your conversations. It's happened to me in the past. We'd like to ask you, firstly, put yourselves on mute if you can, because I'm getting a bit of feedback. If you're happy to, and you can, to put your cameras on. Because we'd just like to really have a conversation now about how that felt doing that exercise. And it's always so much nicer to see people's faces. I completely appreciate if you're in a clinical environment and you can't put your cameras on, please do just leave it off. Lovely, getting to see a few of you now. Wonderful. Oh, no, don't worry if you don't have a camera, that's fine. Okay. So if we can start by just hearing from those people who were in the role of the speaker. So those of you who were brave enough to share something that you've been considering changing or thinking about changing, what was that experience like for you?
For me, it was very positive. It was nice to actually have a chat to someone about something which you've been thinking about doing and avoiding doing for some time.
So it was actually positive for you. Simon. It felt like a pleasurable experience to have the opportunity just to say your thoughts out loud.
Yeah.
Great, thank you for sharing that. Anyone else? Anyone else felt similar to Simon or different?
Yeah, I also found it useful to talk about something that thinking about changing. One thing I noticed, I thought just as we went through the questions, and maybe it's going to come in the next step, and it's not in the evoking step, is that I feel like it would have been useful maybe to discuss the things which are holding me back from making that change, to kind of address those things, address that kind of ambivalence around whether to make the change or not.
Okay, thank you, Ryan. That's such an interesting comment and a really helpful reflection. So you also felt similar to Simon in that it felt helpful, a good experience, but you also wondered whether or not it would be helpful to talk about those things that are getting in the way. And there are always multiple things, aren't there, that get in the way. And what are other people's thoughts about that? Given what you've heard already from the presentation, perhaps thinking about ambivalence, what do you think?
Well, I was going to say something. So I was just interesting in ours. I was the one asking the questions, but that came up naturally. That what came up was the reason why. I think around the question about why you rank yourself a certain number and not another number. I think I did it wrong. I said you were a 7. Why not a 10? And she said, well, because X and Y and Z. Not, you know. So then she came out and said that's what was holding her back. So I think I weirdly got the reasons she wanted to, which were really positive. But then I actually also understood what was stopping her.
Okay. That's really interesting reflection, Andrew, because actually the wording is of the question is really important, and there is a reason why we go lower and not higher, and that's really relates to this point really. Does anyone know what happens when you go lower? When you ask someone why they rated themselves a 6, why is it 6 in terms of importance and not a 3 or a 4? What do you get back?
You get some sort of idea that it's a change that is important for them to make, I guess. It is something that they want to act on. Otherwise it's, well, I suppose if you rated it a 2, then you might think, well, actually that's a very, but I doubt many people do, because they probably wouldn't have even bothered bringing it up in that case.
Do you know, it doesn't actually matter where people rate themselves, as long as it's somewhere on the line. And so actually, if it's a 2, it's fine. Could you say, why didn't you rate yourself a 1? And the reason you go lower is because you get back from the person all the reasons why it's important to change. And you do that on purpose, because you remember the saying, we know what we believe when we hear what we say. We want people to vocalise all of the reasons why it's important for them to make the change, because if they say it out loud, they're more likely to believe it. And therefore the reverse is true. It's called change talk versus sustained talk in motivational interviewing. So sustained talk is the talk where the person tells you all of the things, all of the reasons why they need to stay as they are and not change. That's called sustained talk. And it's not that we avoid sustained talk. We don't eliminate it from the conversation completely, but we want to amplify the change talk. We want to make that louder. If you think about a flame, it's like we want to fan that flame and let it grow. So where possible, we try to sidestep sustained talk a little bit. We don't want to fan it. We don't want the person to tell us all of the reasons why they can't do something. Because again, remember, we know what we believe when we hear what we say. So if I spend 5 minutes telling you all the reasons why going out and being physically active is not something that I can do, I'm going to believe that, even if you spend 5 minutes telling me all the reasons why it would be positive. So that's the reasons why we are specifically trying to evoke change talk. So if you think, again, ambivalence, you've got change talk and sustained talk. and they're normal and they're common, and our role is to elicit the change talk and to make it louder. So what was it like for those people who were the listener and you were asking those questions? What did it feel like?
Hi, I felt there was a lot of questions being rattled up and I almost wanted to make some notes because I knew I was going to have to kind of summarise it at the end.
Yeah, you're actually working really hard, aren't you? Thank you. That's a really lovely reflection. So you're really trying hard to listen as attentively as you can, because I had asked you to summarise at the end. And what I would say, and this relates to the OARS skills, doesn't it, that Helen spoke to earlier, is that OARS sounds really simple. So offering reflection summaries, it sounds easy, but it's a skill and we have to practice it. And at first, it can feel very much as if it's very difficult to listen because you're so busy trying to think about forming a reflection or how you're going to summarise it, and that almost gets in the way. And the only thing that I can say from my own experience, and please chip in for other people who are already using these skills, is that over time that just becomes easier. But I think your reflection is really normal and absolutely what other people have said when they're learning the skills. Yeah, fantastic. Oh, sorry, Helen.
I think my one tip for that would be to just say what you've heard, say somebody's words back to them. That's really powerful. Often we try and interpret something ourselves, and it's quite different to just repeating what you've heard, or even saying to someone, can I just pause and tell you what I'm hearing? And that again is a way to just allow someone to feel as though they've been heard.
Thanks, Helen. Are there any other comments from any of the people who were asking the questions?
Yeah, hi. I was just going to say I think it was quite useful summarising it and then reflecting back, and also the scale. I thought that was really useful. I think it's nice because they wanted to change something. It would be great to know. You might be covering this later about those that you've got an agenda that you want to discuss with the patient, and how if they don't think they need to do more exercise or lose weight, but the figures are showing they do, then it would be interesting to know how to ask those questions and incorporate some of these. I think would be useful.
Oh, and that's such an important point, Ali, isn't it? Because often, and this comes very much back to that agenda setting conversation, and also it comes back to that writing reflex. So often as practitioners, we have a sense of what would be the best change for this person. So just for an example, if they're a smoker, we know that giving up smoking is probably one of the best things that they could do for their health. So it would be our most, the thing that we would want to talk to them about. But actually, we know that probably people have multiple things that they might want to talk about, and maybe that isn't on the top of their agenda, even though it is on the top of ours. And we also know that behaviour change is, well, this, it's complex, and it's easy for the person to start with a thing that's important to them, even though it isn't as important as it, we've got something else that we think is more important. Because if they can start with something that they are motivated by and they have positive experience, they're much more likely to be able to then go on and try that other thing. So I think what you said is absolutely so important. And the only, I suppose my one reflection, and please do other people come in, is that we want to invite someone to have a conversation about behaviour change, and if they're not ready, we would absolutely honour their autonomy to stay as they are, and that's within the spirit of motivational interviewing.
Definitely, yeah. No, I agree that it's and it's useful, I guess, if once you build the trust and for something they do want to change, then hopefully you can work on the rest. But yeah, I think it's a really powerful tool.
Yeah. Right.
Just to add to that, Alison, because I have a story just to share of an experience last week with somebody who came to see me in an MSK clinic who was very overweight, very multiple health problems, and one of those, very difficult, where do you start with somebody, I think. And he was also quite depressed, quite grumpy when he came in. So it took some work to try and build some rapport with him. But my one sort of key change in the conversation with him was to ask him what he really wanted to do. And he talked really happily about wanting to rebuild his classic car sitting in his driveway, and that really sparked something in him. So once I'd got him to think about what he really wanted to do, he was then able to think about to see that to be able to do that, he needed to lose weight. And he made the connection, as opposed to me saying anything about his weight, and that sometimes people do come up with their own solutions, I think.
Great. Are there any other thoughts, comments about that experience? I should have started by saying thank you for bearing with us, because Zach was working really hard to get you all into the breakout rooms and it wasn't playing ball. So really apologies for those people who came backwards and forwards. Any other comments before we move on? I would just say at this point that this is a step in the direction of motivational interviewing, but it is not MI in its truest form. And I would not expect someone to get out that script the next time they're with a patient, or perhaps you might want to try this out on a family member or a friend. So I think this is just to experience what it feels like when you are just asking open-ended questions and eliciting from somebody their own beliefs, and just for the speaker to have felt what it feels like. And most of your reflections was it feels really positive to have an opportunity to think out loud. And often we never have that experience because we have those thoughts in our heads with ourselves. But how amazing it is to have the opportunity to think out loud, and what difference that can make. And, if you went on to do further motivational interviewing training, or for those people who have, you'll know that really incorporating those OARS skills. So we would never just ask a series of open-ended questions, one after the other, in that format. But are we going to move on now? Just before you pop up the slides, Zach, I just want to talk about when we do want to share information with people, because that is important. And Ali's already spoken about what happens if we think that there is some information I want to share with somebody, whether that's about something that we're concerned about, but we want to share information. And I'm just wondering, what strategies do you already have when it comes to sharing information with people? Are there strategies that people use? Anyone fancy sharing before I bring up a slide? No. Okay, that's fine. Zach, can you pop up slides? Because I really want to share with you a really useful skill and a strategy, really. It's a technique for sharing information with people, because there's always going to be times when we feel that I do want to share this information with someone, and this feels really important. And in motivational interviewing, we would use this strategy, and it's known as EPE, elicit, provide, elicit. So what normally happens, and I can talk from, my own clinical experience and trying to learn this over time, is that sometimes we give what we would call unsolicited advice and information. And we just start giving people information before we really ask what that person already knows. And I think this is a very respectful way of giving and sharing an information. And it also is a strengths-based way. So we start by asking what the person already knows and what they would like to, and you could follow that, what would you like to know more about? But I'll start by saying, what do you already know about this medication and your diabetes, for example? Or what do you already know about being physically active and the impact that that would have on your osteoarthritis? So we start by eliciting what that person already knows, because that's respectful, and there's nothing worse, and I'm sure you appreciate this, as being given information that you already know. So asking people what they already know. and hopefully they'll tell you something, and then you would use your OR skills. So you might reflect back what it is you've heard and validate the fact that they are very knowledgeable and there is bits that they know. And then it also means that we don't have to tell them what they already know. So if they know 80%, then we just need to tailor the information and provide them with that 20% that they don't know already. So this can also save us time. So providers, when we give that tailored information in neutral, simple language, but we also would ask permission before we give it. So tell me what you already know. Great, so you already know X, Y, and Z. Is it okay for me to share some information with you, which I think might add to what you already know? And then you share that information, and then you elicit from the person, what did you make of that? What does that mean to you? So it's called elicit, provide, elicit. It can save us time. It's very respectful, and it's a strengths-based way of sharing information with people. And because we are asking permission to share the information, it means it's much more likely that that person's going to listen and take it on board, as opposed to just kind of nod at you and completely not attend to that information at all. So that's a strategy that if you haven't already thought about, that you could put within your toolkit and use and try out over the next few days or weeks. What are there any thoughts or questions? Is this a strategy that actually some of you already use? There are, I can see a few people nodding. Is this something that you think you could try out for those people who haven't already given it a go?
Sorry, I have a question here.
Yeah.
What happens if you ask the question, what do you know about that? And they say something that doesn't make sense to what you expect that they would know. And then if you turn around and say, would you like to know more about that? And they turn around and say, no, I have everything I need to know. And you know it's not right. How do you take it from there?
Yeah, no, that's such a good question. So you ask them, what do you already know? And they tell you something and you think that isn't my understanding at all. And then we move on by saying, you know, you've said X, Y, and Z. Is it okay for me to share some information with you? Because I have some information that's slightly different to what you've just told me. And they say no. And what do we do? And what do other people think you might do in the spirit of motivational interviewing? If someone says no, I don't want that information, what would you do?
I'll probably say fair enough, but I've got a different opinion from what you have, or I've got different information to you have.
Yeah, so we absolutely, however difficult that will make us feel as practitioners, and again, remember that writing reflex is so strong, it's really important that we honour that autonomy, because if we start to tell someone something that they don't want to hear, our engagement with that person will completely deteriorate. And what we tell them will have little impact anyway, so we might as well not say it. But it is absolutely okay to leave the door open and say, look, I do have some other information which is different to the information you told me, and this is available. So if you change your mind, you can always come back and that information will be here. In my experience of using this strategy, in very few occasions have people said no, and when they have said no, they've given explicit reasons as to why they don't, and often it's because they're feeling really overwhelmed. And it happened to me when I was talking to someone about did they want some information about some mental health support, and they just said no, they couldn't even think about that, they couldn't. It was just too much. So just leaving the door open. But that's a really good question to ask. But we'd never give unsolicited advice. If someone said no, we would honour their autonomy. And you might want to write that in your notes to say that you had that discussion, if that makes it feel easier. Okay, we're going to move on. I'm going to pass over to Helen.
Thanks, Chloe. I'll just share that I had that very same conversation yesterday with somebody about going to a pain clinic, and I'd said to her, what do you know about the pain clinic? And she said, well, all I know is they're going to take all my medication off me, and she was very sort of resistant to that. And I said, oh, I don't know if you want me to share some other thoughts about that. And she kind of said, no, I don't want to go there, and I don't want to do that. And I said, oh, maybe next time when you come in to speak to me, I think there's somebody who's a real expert that might want to share some more information with you. And she is kind of willing to that idea. She's going to talk to one of my colleagues who's very expert in pain. So it just goes to show that you have those conversations quite a lot, and you can turn them around. Thank you. Next slide, please, Zach. So our final stage of this 4-step process is planning, and I think we'll all experience with planning that it's the small steps, the initial small steps, that are really powerful. They can really motivate someone into action. So while somebody might have a long-term goal of giving up smoking or losing 5 kilos or something quite significant, it's about trying to support somebody to take the first step, and that's that those smaller goals are much more achievable. People feel as though they're really able to take a small step. So it may be something really simple like changing our environment. We know that creating the right environment around us is really key to those small changes. So leaving your medication by the kettle in the morning to make sure you take it, which I'm sure you've said to people before. Or for me, it's leaving my running gear out in the night before to make sure that it's easy for me to get up in the morning and go for a run. So those really simple, small steps that you talk to somebody about really make a difference, which you'll have in your short conversations with people. The small steps are really key. And it's about managing expectations, I think. So when somebody's plan is quite, you just don't think somebody might be able to achieve that, it's about trying to break it down and agree small goals that are realistic to start with. That makes it more of a success. I think the other thing is about bringing in support. So asking people who else they might need to help them with their next step. It may be, if you're working in a practice, asking about engaging other services, so social prescribers if you have them, or health coaches, but asking who else might be able to help that next step. Just moving on to the next slide, please, Zach. So we've briefly covered these 4 guiding principles, and these are really what underpin motivational interviewing. So we've talked about avoiding the writing reflex. So the idea that we maybe roll with the resistance rather than talk about what we believe or try to influence someone's thinking. It's about really understanding someone's motivations and their values, what's important to them. Using that as your first question can be really helpful. So what's important to you, or what matters to you most? Really listening to someone, which comes back to our reflective listening and saying to somebody what you've heard, or summarising, or even picking up on cues and noticing body language, or if someone's sitting with their arms crossed, just noticing that and saying, well, I've noticed you're sitting, you look frustrated, can sometimes open up a conversation. And then finally, empowering somebody, so really finding someone's motivation to change. So on to the next slide, please, Zach. So prescribing or deprescribing, this was highlighted by many of you who filled in our survey. Thank you for that. And you are the experts in this. So not being pharmacists, we are definitely not experts. But I think there is definitely a strategy that you can use. We'll open this up to the floor in a minute, but there's definitely a strategy that you can use to to help to bring some of these principles that we've spoken about into prescribing and de-prescribing. And there's quite a lot of research around really thinking about, rather for de-prescribing, rather than a withdrawal of treatment, initiating a discussion around risks and benefits of medication, using a shared decision-making conversation, which some of you may have come to Shaba's talk a few weeks ago about shared decision-making, with framing risk and framing benefits, and also framing de-prescribing as a positive intervention rather than taking something away, which feels difficult for people sometimes. So on to the next slide, please, Zap. So our steps to de-prescribing, again, you may have seen these before, they may be familiar to you. The focus we're really interested in is around initiating the discussion and around values and preferences. So the initial timing, so whether somebody's ready to make a change, how stable they might be, how they might be managing their symptoms. And these are questions that you might ask with your provide illicit strategy. I think reviewing, again, using provide illicit, reviewing somebody's response to a medication or their side effects that they're having with a specific dose. And then initiating the discussion comes down to using these principles we've talked about, really, and exploring someone's feelings around making a change to medication. Values and preferences is really understanding what someone's situation is, what their individual needs might be, and what they might need to be able to make a change. And then finally, identifying what support somebody might need in the process, identifying what the specifics of that medication. So if it's all right to take the slides down, Zach, I'd quite like to just invite people to share their experiences of their concerns around de-prescribing, because this is something that was quite a few of you mentioned. So does anyone have any sort of comments, what they find most difficult about this process? I'm wondering sometimes if time feels like a limiting factor. I don't know if anyone's got any thoughts about the time that you have with somebody.
I don't mind sharing a few thoughts about de-prescribing. I think one of the biggest barriers is that people aren't really necessarily prepared very much for the conversation. So it comes to them as a little bit of a shock. And if you're doing this sort of thing on the phone, you don't really have much time to let it sink in and let them really sort of digest the information and maybe come to their own sort of conclusion around, with the information you've given them. I think it can be a bit of a bombardment, and then it turns into a little bit of a well, I've got 5 minutes and I want to get this wrapped up, and you kind of pushing them really in a bit of a direction rather than them wanting necessarily to take you there. So I think personally, it feels a little bit like you're using your skills of persuasion rather than then really opening up in terms of feeling that they're motivated to do it. Yeah. And that leaves you with a bit of a feeling of not sure really whether they want to go there, but at least I've given them my side of the story, and they can then take that away and see what they want to do with it.
Yeah, it's very easy, I think, to fall into persuading, and yeah, you're definitely not alone at all, Simon. I wonder, Chloe, I might get you to share. There's a theory, it's called the 40-20-40, about sharing information with somebody before their appointment. So 40% of the information, and then 20% of the information during the appointment, and then the other 40% afterwards. So that we're not bombarding people with too much information at one time. I don't know if you want to add anything to that, Chloe.
Well, just to say that that was a piece of research that they did in Denmark recently, and it wasn't necessarily pharmacists that did it, but actually it showed really good outcomes that, you know, if we had systems in place where we could share in advance of the appointment information with people, how useful it is for them then to have time to consider it, and then that tailored information at the end. So it is something to consider. But Simon, I was really struck by your that sense of persuasion, and when we move into that persuading, which is so easy to fall into, and I'm sure if not with patients, with our family and friends, our nearest and dearest probably, but how that does evoke from people that writing reflex. As human beings, we our human reaction is to want to be in control and autonomous. That's a natural human reaction, and when we feel like we're being pushed or coerced, we will dig our heels in and fight for our right to remain autonomous. It's called the reactance theory. I think I've already mentioned it. And so even though we feel like, well, I've given them my information, and so therefore I have ticked that box, actually, sometimes it can actually go as far as sending them in the wrong direction. So it'd almost be better not to say it in the first place. But everything you said really resonates with me, and sometimes I think the system doesn't support us, doesn't allow us to have time to have these conversations well in the first place, even if we were really skilled in doing it. Yeah.
Thanks, Chloe. I could just see another hand. Is it Hippolyte?
Hi, yeah, HIP is fine. I was just going to say, from a hospital perspective, we sometimes struggle when it comes to coming up with a plan for deprescribing, because we don't necessarily have the full information. We've got the patient in an acute setting, and it can feel a little bit like not wanting to tread on other people's toes. And then I think our primary care colleagues are like, well, they've been in hospital, they will have had a full medications review, and you know, they would have sorted it all out there. So if they haven't touched those meds, then it's because they don't need that. So yeah. I think that's another big problem. And communication, even though should be quite straightforward between the two of us, isn't. And even though we sometimes write a really detailed plan, I know from experience, if I go, because the patient will come back and I'm like, well, what happened to that really detailed plan of weaning their gabapentin down? And so I think just the changes from each transition is still such a huge task, really.
Definitely. And, you know, if we move on to patient-held records and a bit more, so that the individual has a bit more control over that, I think those kind of things will really make a difference. But yeah, it must be very difficult not being able to communicate between each other. Does anyone else have anything they want to share about prescribing or deprescribing, or how they see this model fitting into that process?
I put it in the chat box, but I find it difficult when there's a patient that's on like an opioid or a Z drug or something that they're sort of dependent on, and you're trying to sort of engage them to, you know, help them reduce and things, but it's very difficult when they just don't want to, or, you know, have been on it for so long that they're just like, well, why bother? I don't really care. So that's quite difficult to sort of get that sort of motivation, because they don't really want to change, and then not to appear too righteous when you're sort of doing those sort of reviews and that sort of thing. So just trying to get that initial motivation is sometimes quite hard. And yeah, we do try and send out letters and things just so they're aware of what we're aiming to do, and so they've got a little bit of foresight into what we're doing. But it's still quite a hard process, and it's a process that we're probably going to try to do for some Z drugs ongoing in the next couple of months. So it's just sort of, you know, making sure that we're all doing it in the best way possible, really.
Yeah. Does anyone else have any experience of deprescribing from Z drugs that they can share? Are you all experiencing a similar difficulties?
I wondered if it's just helpful to just think about the stages of change. I wonder if any of you have seen the trans-theoretical model of behaviour change. It's quite dated now, actually, but it talks about people being in different stages, and sometimes people are in pre-contemplation stage, and that they have to then go through kind of contemplation. That's when someone would be ambivalent, you know, all the way through to kind of an action stage. And I think we do have to, if we really truly want to bring in behavioural science into the work that we do, we need to be able to understand where people are at. And if people are in pre-contemplation stage, talking about behaviour change is almost like you're jumping ahead of that person's readiness. So we need to have different conversations if somebody is pre-contemplation, and we would not be talking about behaviour change until they were absolutely ready and willing, willing and able. And I think often what we do in practice is we assume that people are ready, willing and able because they're there and they've shown up for their appointment. And perhaps we don't spend long enough really assessing where that person's at and tailoring our kind of communication based on their level and their level of activation, so their knowledge, skills and confidence. And I think this is something that if you're interested in learning more about, we have got a slide towards the end of the training, which is going to happen shortly, where we can direct you to further training in health coaching and motivational interviewing, where you can get further support. Yeah, but it is challenging because, like I said, in a way, the systems and processes aren't set up for us to have time for people to have these types of conversations. Okay, well, I think that actually does nicely segue into the next, our final couple of slides, really, because we're drawing to the final 10 minutes of our time together today. So, Zach, if I could ask you to put up the slide around personalised care, which I think is slide 32. Fantastic. So, I'm not sure how many people are aware of personalised care. I expect you all have some general awareness of it. So behaviour change is very much a key part of us embedding this new culture, this new model of care for people, where we really start to give people choice and control, involve them in decision making and use kind of an asset-based approach where we really start to understand people's motivations and build on them. So personalised care is was one of the 5 critical change areas that was highlighted in the long-term plan back in 2019, which feels like so long ago now. But in fact, I think COVID has shone a light on the need for personalised care, and this would have come up in the conversations that you've had with Shaba around shared decision making, is that we need to move away from our one-size-fits-all system to one that is much more about understanding what matters to people, involving people in treatment decisions, and really thinking outside the kind of traditional NHS statutory services box. So there is now a whole team at NHS England dedicated to the spread and scale of personalised care. It is embedded now across policy. It is in the GMC guidance. I'm sure it shows up in your in the guidance that you have as pharmacists as well. And we just wanted to shine a light on it here today. So there are 6 core components of personalised care, which you'll see on this slide. Shared decision making, which you have already covered. There is supporting people to have choice. There is health coaching and supported self-management, and this is really where this behavioural change, behavioural science fits in, building that person's knowledge, skills and confidence. So this is essentially moving away from paternalism to more of that strength-based approach. There is really the use of our link workers, our social prescribers, who are a growing role within primary care networks. In fact, many of you might work alongside social prescribers who can really start to draw on and make use of the community assets that are available to people and broaden out the offers and the options available to people. So finding out where your social prescribing link workers are would be really key. There's personalised care and support planning, and support planning isn't new, but personalised care and support planning is a series of conversations based on what matters to you. And there are 5 key principles that make something a personalised care and support plan. It's worth following the link on this slide to the NHSE web page, which will show you what those 5 key principles are. And one of them is the person is in control and can amend their personalised care and support plan, and they choose who's involved in the development of that plan. And then finally, there are personal health budgets and integrated budgets, which most of you might know as continuing health budgets, S117s, and also wheelchair budgets. But during COVID, we've seen very small personalised health budgets as well for people, perhaps to utilise them to take up different options that wouldn't normally be available to them if they had access to a small personalised budget. And we're seeing services now that are creating budgets for being able to give people these small pots of money with fantastic outcomes as well. So if you wouldn't want to find out more about personalised care, do follow the link on this slide. If we go on to the next slide, please, Zach. There is also something now called the Personalised Care Institute, which has been commissioned by NHS England. And on this, you can access free online training. I'm sure Shaba will have talked about the online training for shared decision making, which is on the Institute website. But there's also some brief skills health coaching training as well that you can access for free of charge. And there's also a list of accredited training providers. So if within your organisations or your teams you wanted to have some further training or support, it would be really good to have a look to see what offers are available there. And that very much leaves us with the last 5 minutes just to hear from you, any comments, thoughts and reflections, perhaps what you're thinking about in terms of next steps before we close for our session. So if we can take the slides down, please, Zach. Thank you. So open to you all, really. This is the final 4 minutes now. If you have any thoughts, questions, reflections that you want to share. Having a few comments in the chat. Thank you for those. And it's a lot to take in. As I said at the very beginning, that I mean, all of my training has been about behaviour change as a health psychologist, and often we would do training that would be at least 1.5, if not 2 days, with ongoing reflective practice. So I still and I know Helen continues to work on our skills, and so it's something that you never feel the expert in, and you continue to learn all the time. So I would say, if it sparked an interest in you, do look at the Personalised Care Institute as a first port of call.
I've just seen a comment about supporting trainees, which I think would be fantastic. So using some of these strategies right from the beginning, it would be really positive.
Yes, absolutely. And we're starting to see now for some allied health professionals that personalised care and these core competencies, these skills, are part of their roadmaps now and their core components, as they are, I think, for first contact practitioners, of which Helen is one. So absolutely, we know that there's some work to do to embed this into people's clinical training. I think it's probably more there than it was years ago, but probably needs to be enhanced. Details on motivational interviewing courses. I could there will be some accredited providers on the Personalised Care Institute, and I am happy to share with Ali and with Ruth some other courses that you could sign up to as well.
Okay,
right.
Thank
well,
you so much, everyone. It's been brilliant, and it's really sparked off some interest. I think it's such a huge topic to try and fit into such a short time, but it's been brilliant for everyone to have some practice as well. And I know, well, I find it very thought-provoking as well. So thank you. I've also I'm just putting in hopefully the link will work for the MedZop Training Hub, because people were asking about further courses. And Ruth and Zach, thank you so much for facilitating and getting all the rooms sorted. Ruth has also posted a session feedback form, so we would be really grateful for your feedback on today's session, and we will be recording this. Well, we've recorded the session, and Zach will be putting that up on the website as well. So thank you so much.
Thank you. Thank you so much. Thank you, everyone. It's been great to meet you all today, and we hope that you have found it useful and will at least try out one or two of the skills or notice what you're already doing. So thank you very much.
Perfect. Thank you, everyone. Thank you. Bye now.
Have a nice afternoon.
Thank you. Bye.
Thank you.